this is an exceptional event for us today because we have Chelsea Roff with us, and Chelsea is a woman who has been involved with the whole issue of eating disorders. She had a significant bout of anorexia, and she did recover from that. But she's done incredible research on this whole issue of assisted death and eating disorders that was recently published, and I'm very pleased that she's doing this event for us. Because she's truly done amazing research. Some of the questions I'm going to ask her, obviously, will be dealing with that specific research. We're going to start the meeting in about a minute or so, and so what's really nice about this situation is that I think she started out by being a person who was very concerned about the issue because of her own personal experience. And why this is important is there's been several research studies published, one particular in the U.S. I'm going to ask her about concerning this whole issue and the whole redefinition of eating disorders as being terminal conditions, which has resulted in people with eating disorders dying by euthanasia or assisted suicide, depending on what jurisdiction they live in. And the one in particular was that Colorado study, and I will ask her about that a bit later. You see, though, she in her study went through the data in the Netherlands, Belgium, etc. She wouldn't have been able to pull up data from Canada, even though there's been stories of cases in Canada also where they've discussed this, because we don't actually publish the stories like that in our research. But she pulled up 60 different cases that she was able to examine on this, and obviously that 60 represents who knows how many that have actually happened, because obviously the research doesn't go through all these studies in the same way. So what I'm going to do is, I know people are still joining us, and I'll continue to admit people. I'm going to ask Chelsea to introduce herself and to tell a little bit about her story, because I think it's important that we get to know why Chelsea has become so involved in this particular issue about euthanasia or assisted suicide based on eating disorders.
Well, thank you, Alex. I'm honored to be here, and I'm delighted to see so many faces. I want to thank you, Alex, for inviting me, and for all of your support actually over the past few weeks. I'm fairly new to the conversations around euthanasia and assisted suicide. So I know that you, Alex, have been in this work for many years. So and I'm sure many of you here in attendance have as well. I just want to also offer that this study, I didn't do it alone. So my co-author, Dr. Catherine Cook-Cottone, is not here, but we jointly did this study, and I just want to honor and kind of call her into the room because it was an endeavor I certainly could not have done by myself. And it was really, I was lucky to have a partner in it, even just emotionally, to have somebody to be talking through cases with. So yeah, I'm happy to give an introduction. And my intent is I can share a little bit about who I am and how I've come to this work, and tell you a little bit about our study. My hope is that you'll read the study because it is a whopper of a paper, but there's so much information in there, and most of it I won't be able to convey in this call. And then I want to make sure I leave time for questions too. It's really nice to be here in community with those of you who are here live, so that I can hear from you and what you have to ask. So as Alex mentioned, I came to this through lived experience. I was very young when I developed anorexia. I was, it's kind of hard to put a pinpoint on it, but probably 10, like really young, just before puberty. And this could be a whole presentation on itself, so I won't go into it for a long time, but I developed a very severe course of anorexia. I mean, my mom would probably tell you that I'm determined and focused and will do anything that is put in front of me to the nth degree, including a mental illness. So it was just, I wanted to be the best at anorexia, and that's actually a very common trait in anorexia, that kind of perfectionism and drive. And I was in and out of hospitals for most of my kind of late adolescence, teens. I went into my first hospital when I was 13, and the system was such at the time that even as a 13-year-old living in Austin, Texas, the closest treatment center that my insurance company would send us to was in Louisiana, in New Orleans, which was like 10, 11-hour drive away. So I was reflecting on this before we released this study, that the first time I was ever told that I would never get better from an eating disorder, I was 13. I was 13 and I was in an adult inpatient facility, not for eating disorders, but for psychiatric conditions, for all kinds of psychiatric conditions. And that was one of the first things I heard in treatment. And of course, it wasn't from a treatment provider who said, you're never going to get better. It was more subtle than that. It was, oh, eating disorders aren't something you really get better from. This will probably be with you the rest of your life. You may never really feel good about your body. And I heard that from other sufferers as well. It wasn't just professionals. So I mention that only because I think one of the important things in this conversation around euthanasia, assisted suicide, whatever term you want to call it, is there's an aspect of almost subtle coercion in our healthcare system, in our society at large. And I know this isn't unique to eating disorders. I know it's true of other mental health conditions. I know it's true in terms of like the ableism and the disability community. But that message, that kind of nihilistic message and cynical message was there, and it was a seed that was planted really early. I cycled in and out of treatment centers, and basically I would go to treatment, go into the hospital, get like 4 weeks of care the first time, 3 months of care the next time, where, I don't know how many of you will be familiar with eating disorders, but we're not great at treating this disorder. Most treatments are marginally effective, maybe modestly effective in adolescence if you look at family-based treatments, but we do not have good treatments for eating disorders. And so I would go get treatment, go home, relapse, and it was this cycle. That resulted at the end of that kind of cycle of treatment. My parents were, well, my mom in particular had a mental health issue of her own, so I was kind of had sort of free reign to act out in an eating disorder for a period of time, and I ended up with a BMI in the single digits, which is a very, very low BMI. Often people don't come back from that. I don't like to tell weight because it just ends up triggering people or giving people, competition stuff. But I was very, very sick. I had multiple failing organs. I don't even really remember how I got to the hospital. I remember waking up in a hospital in Dallas, which was 3 hours from my home, and not being able to walk, and not having any control over my bladder, and not having, just any sense of where I was. So I was really ill. And again, that could be a story of its own, but I ended up in the hospital for 1.5 years. I was in a wheelchair for the first 3 to 4 months of that. I was told multiple times that I was one of the sickest cases that they'd ever seen, and I had a cardiologist, I remember, tell me, I remember saying, you just need to let me go home. I don't want to be here. And her saying, I don't know if I'm going to be able to keep you alive till tomorrow. I'm certainly not sitting at home. So I was really, really sick. And I'll say, I think the last thing I'll say about this part of how I come to this issue is, when I got to the hospital, I wanted nothing more than to just be allowed to die. I was so done. I was so done. I'd had this illness that had just taken over my life. I had a very difficult home life at that time. And I verbally asked them, just let me go. And I remember being so angry at the fact that I didn't even have the agency to commit suicide. I didn't even have that ability. I was trapped and locked in a hospital. And I just remember being so furious that I didn't even have the ability to end my own life. I was so mad. I was so angry. And I'll say, it probably is apparent, but let me just say it directly. If the option to end my life had been put in front of me by a medical professional, I 100% would have taken it. No questions asked. No questions asked. So yeah, sorry, you think about that, and I'm gonna kind of pull out of that time of my life. It was a really dark time, and I am so grateful that the physicians that were in charge of my care did not give me that option. and did not let me go home. For a year and a half, they didn't let me go home until I was better. I had amazing physicians. I had amazing nurses. I hated them most of the time in the first few months, but I got a lot of tough love, and I am alive today thanks to them. And I hold them in my heart every day of my life. I'm so grateful to them. So I come to this paper with those stories inside of me, all of that. I carry all of that in me. I fast forward when I got out of the hospital and had recovered, first thing I wanted to do was study the brain and figure out how things went so wrong. You know, I really did. I wanted to understand. So I went and studied neuroscience and psychoneuroimmunology. I developed a real interest in yoga because yoga had been a really important and valuable part of my recovery. And I mean, it was a game changer. It was more helpful than any psychological therapy had been up until that point. And I don't think yoga is a panacea. It just really fit for me. It was a really good moment in time. And I can also do another presentation on that. So I ended up studying yoga and looking at yoga for people with different actually immune conditions in university. And I really wanted eventually to look at a yoga program for eating disorders, but I couldn't get the funding because the NIMH doesn't fund yoga and the NSF doesn't do that kind of stuff. So I ended up doing a crowdfunding campaign and raised about 50 grand to do a study on yoga. And I just got sidetracked into it was supposed to just be, a single study, but then I raised that money, put it into an organization as a nonprofit. And I've spent the last 10 years running a nonprofit organization to help people recover from eating disorders. And we use kind of a combination of yoga and mindfulness and psychological therapies. So my work these days has nothing to do with death. It has everything to do with life. It has to do with helping people. I've worked in inpatient settings and residential settings, and outpatient settings. Most often I'm working with people who can't get access to treatment. And we're delivering programs because there's, we just actually did a study on our program, and most of the 250 people that were enrolled in that study had their eating disorders for more than 10 years and were not, had already done treatment. So that's where my work is now. I came to this because, like many in the eating disorders field, and I've gathered, throughout the world, about 2 years ago, I heard about an academic paper that was proposing a new kind of clinical category for eating disorders called terminal anorexia. And I thought at first, I read the paper, and actually I was thinking about this. I got asked this yesterday on a podcast. And Catherine, my co-author, and I were asked how this all started. And it started, it's going to sound like I'm being dismissive, but it's not. I actually sent Catherine my research. We've done multiple studies together, and she is in academia and she manages an academic journal. And I sent her the paper and I said, is this a legit journal? Because I couldn't even believe it had gotten published. I just was flabbergasted that it had made it through peer review. And that's how it began. So we started talking about the paper. Catherine is a psychologist and a researcher, and also has lived experience of an eating disorder. So we started, there's a big outcry in the eating disorder field. So I think initially I just thought, this is kind of being taken care of. It's not like the field came and went, oh, this is a great idea. You didn't see a single positive paper come out. It was a slew of rejections and response papers and calls for the paper to be redacted. It has still not been redacted. It still is out there. So I thought, okay, that's being taken care of. And Kathy and I started talking, well, maybe we'll add our voice to this discussion from a lived experience perspective. So maybe we will come at it and we'll kind of share from lived experiences what we think about it. But, we thought, okay, our field is coming together. This is not a good idea, and people know it's not a good idea. And then I went to a conference this past February, and thinking that, all is kind of moving ahead, the field is coming together. And there was there was a plenary presentation where one of the authors of that initial paper and three or four other I think it was four other presenters spoke, and there were two presenters who were pretty critical of the idea of terminal anorexia, and there were three, so 2 to 3, and the two critical voices were sandwiched between the other three. So, the first word and the last word were pretty pro-terminal anorexia. And I should say it wasn't pro-terminal anorexia. There was what I understood to be a rebrand of, okay, we're not going to call it terminal anorexia. Let's call it phase 4 anorexia. So we'll just say, there's phase 1, you're not that sick. Phase 2, you're kind of a little more sick. And I'm just sitting there going, where is the science behind this? Like, not a single study cited. And I'm trying to stay professional, but if you're going to present an extreme idea, there must be extreme evidence behind it. So I was surprised, and I came out of that presentation with the sense that this was not stopping, and that the terminal anorexia had almost been a distraction, because the real issue was the fact that pretty young women, I mean, they said over 30, we found under 30 as well, but pretty young, mostly women, were being prescribed lethal medications. That is the issue, just directly. It's not whether we call it terminal anorexia, and all that's a problematic thing as well. But the real heart of the issue, I feel, is that we have individuals with a mental health condition being prescribed lethal medications by their physicians, and physicians who would normally be expected to provide treatment to prevent suicide. So I found that remarkable. And I think what also I found concerning, coming from a scientific background, I was saying to Alex before this call, I think, on this issue, you can arrive at it from many different perspectives, viewpoints. You can come at this from there's people that arrive at, I don't think this is a good idea from a religious perspective. There's people that come from a humanistic perspective. I came at this from a scientific perspective, and of course a personal perspective. But from a scientific perspective, the evidence is not there to state that we don't have enough evidence to make any good predictions of a person's prognosis with an eating disorder at any time point. And we certainly don't have the evidence to suggest that because a person has been ill for a long time, or because they've endured more than one relapse, that they're unlikely to ever recover. And what concerned me is that those statements were being made as if they were medically sound or evidence informed kind of ideas. And I knew that they weren't. And they were being used, I have to bring us back to this over and over again, as a justification to provide a lethal medication to a vulnerable young adult. So that was my concern. And at as that conference went on, Catherine and I would get together every night, and partially just as emotional support to go, what is happening here? And I think what was concerning to me as well is that there were many professionals in our field that were at least on the fence about it, and some of whom went, oh, I don't know. I think, there's some patients that just nothing works. And this might be the best thing we can do for them, is just to put them out of their suffering. And I was really, it took me a couple of weeks after that conference to really come out of that kind of grim, drear. I just was kind of struck by the nihilism. I was struck by the cynicism. I know eating disorders can be a very difficult illness to treat. I'm so grateful to my clinicians. Again, I bit a nurse once. I was a horrible patient. They cannot be blamed for going, I've had enough of this kid. But that's why we have laws, to keep kind of ethical practice in place. So I was struck by, I know burnout is an issue with eating disorders, and I was struck by just kind of the mentality in some of the clinicians I was speaking to. So Catherine and I got back together, and I said, well, I think this is going to warrant more than a lived experience piece. We started on a literature review to try to dig into some of the concepts we were seeing being used as justification. So I mentioned one, which is in kind of scientific speak, duration of illness as a predictor of prognosis. So meaning, can we say because a person has had a long course of illness that they're unlikely to get better? Can we say that? Does the research suggest that's true? And interestingly, it actually suggests the opposite, that the longer a person has been ill, the more likely they are to recover. And we don't have very many longitudinal studies, but the ones we do have show the longer you follow up patients, if you follow them up for more than 10 years, more than 20 years, more and more of them get better. And this illness is protracted at this point because we don't have good treatments for it. So I go, that's actually the nature of the illness, is that it's, at least at this time when we don't have good treatments for it. We also, and I'm kind of speaking to some of the stuff we found in the study now. I can pull up some of my slides, but another thing we were seeing spoken to a lot is autonomy. Okay? So we were hearing this kind of, we were hearing clinicians say, well, we have to support patient autonomy, and this is autonomy, supportive care, which was concerning. So anyway, I'm going to get my slides up now, I think. But I'll say that we were seeing those things. We went into a literature review, and I said, I don't think this is going to be a strong paper unless we really look at the data and see if these kind of rationales are being used. So we ended up doing an international review of every kind of a psychiatric case of euthanasia or assisted suicide we could find. So we poured over, I counted it up, I think it's over 120,000 records that we looked at in the end. So it was quite a lot. And we started with the scientific literature, and then we moved to the government records. So let me show you a little bit about what we did. Just briefly, terminology wise, there's so many terms. I think I've got it here. So you can see here, I've just kind of threw it onto a visual, but you hear in the US and North America, you hear the term MAID, you hear death with dignity. In Europe, we hear terms like assisted death or assisted dying a bit more often. In the Netherlands and Belgium, you hear euthanasia. In our paper, you've got to pick some terminology. And of course, I know Alex is familiar with this. Often terminology is selected for the purpose of shaping public opinion. So, I'm also speaking in our paper to a scientific audience. So I have to be pretty, I need to know who I'm speaking to. So the terms we used in the paper to talk about this practice broadly across all countries were assisted death and assisted dying. We didn't use physician assisted because there are countries in which physicians are not directly involved in the process. So those assisted dying and assisted death are not my favorite terms. I prefer to use actually specific language when we're talking about specific cases. So I'm sure many of you will be familiar. Euthanasia is when a physician actually administers a lethal medication, and assisted suicide is when they prescribe a medication and the person self-administers. And, for the purposes of clarity, if I'm saying assisted dying, assisted death, I'm just trying to talk about both of those practices at the same time, but otherwise I'm using specific terminology. I don't think in this audience I need to explain why I'm not using death with dignity or MAID. Okay, so one of the first things we do, if you read this paper, the first half of the paper, what we wanted to do is bring actually the eating disorder professional world up to speed on this practice, because what we're seeing is just even something as like mental capacity, which is, something really critical to this debate. People didn't understand what that meant. So they would say, well, this patient, is intelligent. So, and they're speaking really clearly, so they must have mental capacity. And it's like, well, actually mental capacity isn't about intelligence. And, it's not a characteristic of a person, but it's specific to a situation. So what we did is we looked at every jurisdiction where assisted dying or assisted death is legal in the world right now. And we looked at the common eligibility criteria. And for simplicity's sake, really most jurisdictions, not all, Switzerland is as an outlier, either make assisted death, assisted dying legal on the basis of the person having a terminal condition, or the more kind of loose criteria would be where the person's condition doesn't have to be terminal, but it needs to be irremediable, meaning it needs to be incurable or unlikely to ever get better. And I remember Alex and I in our first conversation going back and forth about this. I was saying, they say irremediable in all these different ways. So, in Canada, where many of you are, it's a grievous and irremediable condition. In Luxembourg, they say an incurable medical situation. And in the Netherlands, they say it's a condition without prospect of improvement. All of these are talking generally about an irremediable condition. Scotland, I've just learned because I was asked to comment on they're debating an assisted dying law. Oh my God, I was asked to comment on this, and they say it is that the bill, if they call it the assisted dying for terminally ill adults. But if you look at the definition of terminal condition, they define it as an irremediable condition. So it's actually, they use the word terminal, but the actual definition is more in alignment with an irremediable condition than a terminal one, which is remarkable. So that is, and I'm smiling. I'm like, the ludicrousness of some of this stuff is, it's not funny because of what we're talking about, but it does, you almost have to laugh because you're like, how did this get through? How did this get through even to be a bill that's been considered? And in almost all countries, a voluntary request. So not almost all countries require that the person is making a voluntary request. And one of, I think, the challenges with this issue is that people don't fully understand what it means to make a voluntary request. So they say, well, the person is expressing their autonomy or they're making a choice. And we go, okay, well, let's really talk about what it means to make a choice voluntarily. The Nuremberg Code set out what informed consent is. This is not a new thing. We've had issues of not having consent in the past, and it's why we have these guardrails. So, and then I'll just mention that Switzerland has the unique, it's pretty open in Switzerland. It's been legal since 1942, and you don't have to have an irremediable condition. You don't have to have a terminal condition. The only real strong requirement is that the person who's providing assisted death must not have selfish motives. And then there's a number here you'll see where it's been legalized, but it's not yet regulated. I joke that Montana, I don't know that they have any intention to regulate it. It's legal through the criminal system there, but there's, I just say that Montana's the Wild West. There's no real restrictions in place there. I'm gonna, just for the sake of time, I'll let you, this is in the paper and it's a nice kind of graph, but it basically the same as this last slide. And then I'll just briefly say that, especially when we were bringing eating disorder clinicians up to date, one thing we wanted to let them know is that in some parts of the world, namely Netherlands, Belgium, and Switzerland, and now Colombia, assisted death is legal for minors. In the Netherlands, they've got the Groningen Protocol for infants. Between the ages of 12 and 16, you need parental consent. Of course, you can't get consent from an infant, so that would just be based on parental consent. And then 16 and up, you actually don't need parental consent in the Netherlands. You just need your parents to have been involved in the decision somehow. So, I think the other really big concerning thing that I'm watching very closely, and I have tried to drive home to clinicians in the eating disorder world, is that while I live in the UK, it's not yet legal here. Hopefully never will be legal here. And so I talk to people here, they say, oh, well, it's not legal here. And I'm like, no, but there's many countries in the world that don't have residency restrictions. So we live in a globalized world. In Switzerland, nearly half of the euthanasia or the assisted suicide deaths in Switzerland are non-residents. They're people who have traveled to the country. They have an entire organization, Dignitas, one of their assisted suicide nonprofits, that is only for foreigners. They've got a special one for foreigners. So it's really not just, we live in a globalized world. When one country legalizes these practices and then it affects all of us. I'm not going to go deep into this in this presentation just for the sake of time, because I want to get into our results. And I will mention a bit about mental capacity, because mental capacity is I wish it were sexier because it's so important. Forgive my language there, but people kind of gloss over it, this idea, but it's so fundamentally important. One thing that I think most people are not aware of is that there are no assessments of it. So all of the laws say, we've got these great safeguards, the rigorous safeguards. Person has to have an irremediable condition and they must have mental capacity. But that begs the question, how do we determine if a person has mental capacity? And what surprised me in this research is that determinations of mental capacity are almost always, there's no standardized assessment for mental capacity in assisted dying decisions specifically. And this is generally a clinical judgment, meaning it is a physician or a nurse practitioner making a judgment based on their understanding of mental capacity. There are great clinicians out there that are really good at assessing capacity. I had one such clinician, a forensic psychiatrist, say to me the other day, and I'm just going to keep this because she put it so well. She said, to be found to not have capacity in one of these decisions, you would pretty much have to be comatose. And that is her job, is to assess capacity. And she further said that the bar is so low that you really only need to understand two things. And she was talking about the US in specifically, one, that you have a terminal condition. And so you have to understand that you have a terminal condition. And two, that if you take this lethal cocktail, that you're going to die. That is the bar for mental capacity in assisted dying decisions in the US. So that's a very low bar. I think it's important in terms of what we actually know about mental capacity. It's not reflective of a person. So I wouldn't be able to say this patient characteristically lacks capacity. When we measure mental capacity, we're looking at a particular patient in a particular decision. So does this person have the capacity to make this specific decision with these specific consequences at this time, in this context, in this social context, cultural context, healthcare context? So that is often lost. And we don't have any standardized assessments for mental capacity in assisted dying decisions. We are famously bad at assessing mental capacity in eating disorder patients in treatment decisions, which have a much lower bar for, because they're relative to risk, which is the third one here. Decisions involving greater likelihood of risk require more evidence of capacity. So, to be found incompetent or unable to make a decision in treatment. So for instance, if we're asking, does this person have the capacity to refuse treatment? The bar is lower than, does this person have the capacity to elect to take a lethal medication that will end their life? That is a lower bar. And even when the bar is lower, clinicians get it wrong about a third of the time in the studies that have been done. So that tells me, even eating disorder clinicians are not very good at assessing capacity. What do you think about, physicians that don't specialize in this disorder, or a physician that hasn't known this patient for the past 10 years and seen what they're like when they're not malnourished and undernourished? So that is a really big issue. We talk about safeguards, but again, with all of these issues, what I found is that as soon as I kind of went to grab hold of it and go, okay, what is this? It just crumbles. There's just nothing there. So, we're told, well, there's a safeguard. Physicians check to see if that person has capacity. And I'm going, do they? in what, what assessment are they using? How good are they at doing this? And with such a high risk issue, I think we need to be really certain. really, really confident at least. This is, we have another kind of visual. It's not this specifically, but this just, I'll briefly say, one of the things that was striking to us as we looked at assisted dying laws is that most of them start out, seemingly fairly kind of restrictive. So they'll say, oh, only terminal conditions or only irremediable conditions. But if you follow over time, you see a progressive loosening of those restrictions. And my personal theory on this is that it's related in some ways to our concept of human individual rights in the West. It's related to our idea about mental health parity. So there's this idea, well, if a person who has cancer is suffering and has the right to end their life, because we start to talk about it then as a right to end their life, then shouldn't a person with a mental illness, like, aren't those, that's called mental health parity. So we would say, well, isn't a suffering related to a mental health issue just as legitimate as the suffering related to a physical health issue? So we're almost seeing this sort of, I think, warping of a really important principle in healthcare, that of mental health parity. So I think that's part of why you see this loosening, as we start to go, well, if you're giving this right to some people, why aren't you giving it to others? And I think it's a misconception to think of it as a right to begin with. And that's part of actually this something I've come to is I've talked to many people who say, well, don't people have these laws, we need to give people rights of autonomy. And I think these laws don't typically grant new rights to patients. They actually just give legal protections to physicians. And they also give a tremendous amount of authority to physicians, especially in the context of mental illness. So that concerns me. I'm going to skip through these slides just because they're my favorite slides, to be honest, but I'm really into numbers. But I'm just going to summarize it so that we can get to the big stuff, to say, let me go back a slide. Most of the data, when we went, and so let me actually cancel out of this for a second, because sometimes it's nicer to see. When we started doing our literature review, we started with the scientific papers. That's where you usually start with a systematic review. You don't usually go into government records at all. So we did a systematic review of the scientific literature to see, are there cases reported of assisted suicide or euthanasia in patients with eating disorders? And there's not a lot, but there were a handful. And I was aware that there were cases that had occurred that were not reported in the scientific literature. So I thought, oh, maybe we should go and look at the government records. So just an example of that, there was a mention of an anorexia death in the Oregon Death with Dignity report, certainly not in the scientific literature. So I thought, okay, best practice, let's go and review all of the government records in countries where assisted death is legal for psychiatric conditions. So that gave us
a comment about that. The
yeah.
Oregon report refers to it in the other conditions, but it doesn't actually tell me
how
many assisted suicides were done for anorexia.
Yeah, and I'll tell you that, get into that in a minute as well. Yeah, it doesn't list it as a condition. It just mentions it in a footnote. But anyway, all to say, we did a review of government records first in countries where we knew it was legal. So that was the Netherlands, Switzerland, Belgium, and Luxembourg. And then, for good measure, knowing that these patients there was a mention in Oregon that had been published in a government report, we went ahead and just reviewed the 77 annual reports in the United States as well, which was nice bedtime reading. It was a lot of reports. So what I'll say just is that most of the data on psychiatric cases is not available for public scrutiny. The vast majority of the data on psychiatric cases, and I can't hammer that home enough. This is such a serious practice, and the fact that there is so little oversight and so little reporting on this is very concerning. Even in the Netherlands, where their reporting is much better than any other country. We couldn't look at 76% of the psychiatric cases. We only had access to 24% of them. And that was the best country. Switzerland does not do any annual reports at all. I can't get an account of how many deaths have, at least in the other countries, I know how many deaths total have occurred. Switzerland presumably has done the most, given it's been legal since 1942, and you can't get an accurate count of that. So there's massive gaps in reporting. We were able to identify in total 60 unique cases of patients with eating disorders who were euthanized or assisted in suicide. These were cases that occurred in Belgium, the Netherlands, and the United States. In the United States, assisted suicide is only legal for terminal conditions. So that is, concerning. In Luxembourg, I was able to rule out cases of eating disorders from their data because they do publish reports and they've explicitly said that while psychiatric euthanasia is legal, it has not occurred. There have been 0 cases thus far. In Switzerland, I could not confirm or rule out cases. In 76% of the cases in the Netherlands, I could not confirm or rule out cases. So 60 sounds small, but it's only representative of 1.5% of the cases out there. So that's part of why that number is so small. Of those 60 cases, 19 of them had what we call qualitative case reports. So they had descriptions of the patients and their circumstances. And that's kind of the bulk of our analysis. So what we did is we took those 19 cases and we did what's called a content analysis in research, where we extracted the medical rationales that were used to justify euthanasia or assisted suicide in each case. So that was just coding. Spare hours and hours and hours. Some of them, and it was really difficult emotionally because you're reading cases about real people, and many of them were young. A third of the 19 cases involved patients between the age of 18 and 30. So, and I'm just going to say that again: a third of the cases were people in their teens and 20s, and 100% of the cases were young women. A second third was in their 30s, and then we had I think it was 26% over the age of 50. I should look at the statement just to make 100% sure I'm being clear. So those were the ages. I'll make it you. Hold on. Yeah, here we go. 26% were over the age of 60. It was not just anorexia, it was multiple eating disorders. There was at least one case where the eating disorder was named an eating disorder and there was references to binging. So that could have been bulimia, it could have been binge eating disorder. They didn't name the diagnosis. It could have been, you don't usually see binging and anorexia, but it could have, it's possible, but the person was not described as underweight. There was, in terms of psychiatric, I'm going to pull up my slides again. So this is ages here, which we just spoke about. You can see the vast majority were anorexia, but there were 37% of cases where it wasn't specified. It's 68% of cases the patient was severely underweight or malnourished. And I have to highlight that because having been severely underweight and malnourished, from a personal experience perspective, I can tell you it absolutely affected my thinking. It absolutely affected my judgment. It affected how I saw the world. Anhedonia, or it's lack of feeling of emotion. It's like being completely emotionally numb is associated with being underweight. There's also, we know that people who are severely underweight or malnourished with anorexia show brain atrophy. They show cognitive impairments. So the fact that they were making a life-ending decision while underweight and severely malnourished is something we should be concerned about. 37% of the cases, the patients had attempted suicide already. So it was very odd to read this case where they would be saying, well, the person's wish to die is not an expression of mental illness in one breath. but then talk about how depressed that patient was, how they were having nightmares, and how they had previously attempted suicide. So it was this very, I don't know how, it was a really strange compartmentalization of their previous psychiatric symptoms to their wish to die. I don't know how that was, how those were made distinct. We saw that in 26% of the cases, the patients had become physically disabled as a result of their illness. So I think this is something we're hoping to actually a panel discussion on in the next few weeks, and that kind of overlap between disability and eating disorders. And then I just want to get into, I'll just briefly say this data is in our study, but comorbidity, there 95% of the patients had more than one psychiatric condition. 61% had 3 or more. So these were really, severely mentally ill people. And it breaks my heart that they were not being given the treatment they needed at that moment instead of lethal medications. Really, the heart of our paper is looking at the medical rationales and the clinical rationales that were used. We look at them in 3 categories, and this breaks it down, but they won't be surprising to you. I mentioned this one earlier, this one here at the bottom. We would see them say that the wish to die is not a symptom of mental illness. That is a very strange thing to make, because usually we understand a wish to die as suicidal ideation. That's exactly what we would call that. We saw in 95% of cases, they claimed the patient had decision-making capacity, but we saw indications that they might not. And we kept seeing, this was the thing that I saw the most, I spoke to in the beginning, this idea that the patient has been ill for a long time, and thus their condition is irremediable. The patient has had treatment prior and not gotten better, thus they will never get better. So there were some really strange rationales here. We saw in 47% of cases, so nearly half, the clinicians reject or dismiss available treatment options. We saw them describe treatment as an undue burden on the patient. And what concerns me most is that most of these statements were presented with a high degree of medical certainty, but the evidence in the scientific literature is not there to have a high degree of medical certainty for those claims. And in fact, again, sometimes we see evidence that directly contradicts the claim that was being made. So I think I might pause there. Alex, I want to make sure there's time for questions, and I've got a close to hard stop on the hour. So that gives us about 10 minutes to have questions.
I will say something, you can, if you have time to comment on the end. There was that study that was done, recovery from anorexia nervosa bulimia at 22-year follow-up, that was done in 2017, which is
The Eddie study.
That I refer to quite often when they were referring to the study out of Colorado, which was claiming that people were had terminal anorexia, and that didn't fit according to that long-term study.
Yeah, there's been multiple long-term studies actually that have shown that. The interesting thing is, the longer you follow, if it is a long-term study, it shows much better recovery results. So that's part of the issue here. The Eddie study is great. That reminds me, Alex, maybe I'll speak to the thing you were bringing up earlier that I didn't get to speak to, which is in the United States, we really struggled to find reporting. So Alex mentioned this in the Death with Dignity report in Oregon. There is a mention of anorexia in the 2021 report, I think, that it's in a footnote, and there's a category that says other illnesses, and there's 7 people listed in that other illnesses, and anorexia is mentioned in the footnote as an example of an other illness, but it doesn't indicate how many of those 7 had anorexia. That kind of touched me off too. I'm like, other illnesses, interesting. How many other states in the US have this other illnesses category? And nearly all states have that category. Almost none of them outside of Oregon actually define what's in that category. Hawaii does a pretty good job of it, but the vast majority of them don't. And there's a sizable number. We're not talking 7. We're talking about, all of them together, probably at least over 100, because sometimes it's 30 people in the other illnesses category. So that was very concerning to me, because I go, well, how many people with eating disorders or other psychiatric conditions are in that? I can't see as a researcher. In Colorado, I knew that there had been patients with eating disorders who had died of through assisted suicide, but it was not mentioned in any of their annual reports. So I thought, well, that's concerning. So I reached out to their reporting department and spoke to an official who was lovely. He was actually incredibly helpful and gave me as much information as he could within the bounds of his restrictions, but was able to confirm that yes, anorexia has been reported as a reason for prescribing MAID in Colorado in previous years. No, it is not reported it's not included in the annual reports as a separate category. It's included in other illnesses. So it's in that catch-all category that if I didn't know, I wouldn't be able to recognize from their annual reports. He couldn't confirm how many. And he was able to say that he's noticed a sharp increase in a new category, which is called severe protein calorie malnutrition, which sounds to me suspiciously like starvation. He could not tell me the ages of the 12 patients that have been received MAID over the past few years from that. I will stop talking because I see hands. So I will go to you first, Heather.
Thank you so much for your presentation today. I'm just thinking back to my own, I don't have a personal experience with anorexia myself, but I did have a very good friend when we were teenagers deal with a very severe case of it that went on for a number of years. And she was very suicidal as well. And it was the mid-'80s, so there was very little treatment for the situation. But in her case, the root cause of it was sexual abuse in her home. So I just wanted to know if you did any research around some of what the root causes of these kind of things are, or if you're just simply doing the research as in regards to the euthanasia that's going on in modern day time.
Oh, thank you. That's a great question. I'm very sorry to hear about your friend, and it's a common presentation I see. There's often trauma behind this. I have not done that particular research. There's research that's been done showing that sexual trauma and trauma generally is highly correlated with eating disorders. And often, there used to be a metaphor in the field that is not a very nice metaphor, but it was genetics load the gun and trauma pulls the trigger. So that, I don't love the gun metaphor, but I think it's pretty apt. And I actually did see a presentation at ICE this year, but they have not released the slides. They haven't published the paper, and they wouldn't let us take pictures or anything, but it was on euthanasia in the Netherlands, and the rates of PTSD and sexual trauma in the patients was very high. So I'm hopeful that research will be published. Great question. I see two more hands up.
Thank you very much indeed. Listening to your presentation, and I really commend the research that you've done and how you've managed to dig for all this data. I wasn't clear how many of the people so-called doing the assessment for eligibility actually were people who had been trained at all in doing assessments for mental capacity in this cohort of patients, because capacity fluctuates and assessment is extremely difficult anyway, even in a normal setting, let alone in people who've been traumatized. But also whether what you would recommend as a better safeguard than two doctors behind closed doors making a decision which doesn't have to be reported. And I wondered whether you'd got any insights from Quebec, where I think they have to at least report that somebody's made a request, and whether you feel that it's essential that made is on the death certificate. So there would be an audit route to know how this person had died.
Wow, that is a great question. The first part of your question around the physicians or the psychiatrists that were doing the assessment, we couldn't report on that because in some cases it was identified whether the physician had a specialty in eating disorders, and sometimes it wasn't. I will say that from my memory, it varied across the board. So sometimes it was the person's GP that was writing the prescription, and in some cases, the person's GP and psychiatrist had refused the euthanasia request. And so this person went to a specialized euthanasia center and saw a healthcare professional there who had never met them until that request was made, which is concerning to me because your personality changes in the throes of these conditions. So it's hard to recognize those fluctuations in capacity if you don't know the patient well, as you've spoken to. So I'll say it wasn't standardized and it varied across the board. I think, I have to say when I started this, I was very middle of the road in terms of kind of the law around assisted suicide and euthanasia. I can think of cases, where I go, God, that would be the most compassionate thing. I can think of those exceedingly rare cases, in eating disorders, and then I can think of in just the general population. I can go there in my mind, and I went, well, maybe this is a positive thing. When you ask about what would be an alternative safeguard, I don't think we're anywhere close to there to being able to implement a safeguard in eating disorders and psychiatric conditions, because a safer safeguard, I don't think it would be 100% safe, would be one that is standardized and backed by research. And that does not exist. We don't have that research. We don't have standardized assessments. And that takes years to do in research to develop those types of assessments. I also would just say that I'm not familiar with the Quebec law, but one thing that concerns me about Netherlands and Belgium, it's good they at least have a review board that looks at things after the fact, but it's after the fact. It's after these things have already happened. And the cases that I was looking at, those look like unjust deaths to me. So that's concerning to me. So I don't think we can have this is part of where I've kind of moved on this a little bit through my research. I can't envision a way in public policy to have a board that's, deciding whether this is a good case, to do that preemptively is also not a practically feasible thing. So
why do you say that?
Because it's scale, at scale, having requests come to a board that is going to evaluate every single decision and look at that patient in their case, that's in terms of, what we can deliver at scale at a countrywide basis, we have better things to be spending our money on.
Well, I just wonder whether what you're saying is that this is autonomy. This is masquerading as autonomy, but actually it's financial rationing, because some of us live in countries where the law hasn't changed, and we hardly ever see requests for life-ending drugs. And when we do, 99.999% of those vanish when patients get the care and treatment they need.
Yeah.
So I just, a statement like you couldn't have a board to look at these people beforehand, I'm challenging you slightly on, because I don't see where the evidence base is for that.
When you say, so what I'm saying is, if we were to legalize assisted dying in a country, and we were going to give a board the responsibility of reviewing every single assisted dying request that comes through beforehand, I'm saying
Yeah.
that's very difficult to deliver at scale. And I'm not a policymaker, though. I would imagine that's going to be a very difficult. I imagine that's why the Netherlands is doing it after the fact. Is because to set up that kind of board to review each case would be like a capacity nightmare for a government. What I would imagine. But that's a very interesting case, and I agree with everything you said around, you know, most these cases. Most people, when they present asking for these medications, those with sufficient care, those you know, those usually
Just
go
goes.
away. I have time
Just
for
another
one more.
hand up.
One more question. Yeah.
Okay. Yeah, it's Claude Regnard, a retired palliative care consultant. I was interested in whether you'd come across the impact of bereavement on the families of those who died. I'm thinking particularly, in theory, an 18-year-old who's an adult can have the choice of not telling anyone else, in other words, not telling their family. I wonder if you'd come across any cases like that, or bereavement follow-ups where there'd been real problems.
I've not in eating dis That's a really good question. I've not in patients with eating disorders. You know, I've actually worried about the opposite. Even publishing this study, these are real people and they have families, right? And so I've really worried about actually what it may feel like to see this conversation brought to the forefront, and to see the conversation around whether this was a just death or not, you know, whether this was appropriate. I worry actually about that part of the bereavement of, you know, almost a case being used for the purpose of having a conversation about whether this is an ethical or not unethical process. I've been very sensitive to that. I have read about cases in the Netherlands where individuals made the choice to undergo euthanasia without telling anyone in their family, and I can only imagine. You know, I've sat and thought about it. You know, my own you know, mother who deals with quite a lot of pain. I've thought, oh my God, what if, like, how would that feel? That would be absolutely horrific. So it's introduced it's funny, we focus on a single case, but we forget that that person is part of a system. They're part of a family system, a community. And so, yeah, I appreciate your question. I think it's a really important question. And I worry that just the delicacy that's needed to talk about these cases, because their families are still there, you know, and I don't want to in any way send the message that, you know, it was wrong that you didn't do something, or I do worry about that kind of actively at this moment. But at the same time, I'm thinking about the people in the future who do not yet have eating disorders, and the people with eating disorders in this moment, and just trying to do all I can to ensure that there are protections in place for them.
So for everyone here, Chelsea said that she was willing to let this go 5 minutes over, so we've done that.
I've got somebody texting me asking me about the next meeting, so I think I'm supposed to be the one to open it up.
If anybody does not, is Chelsea willing to respond to people's questions?
I'm happy to send them my way, and then we're doing a series of events. So come to another event. We've got one, I think, on the 22nd of August. We're doing another panel discussion with Agnes Ayton, who's the vice chair of the Royal College of Psychiatry, or vice chair of eating disorders in the Royal College of Psychiatry, and a number of really exceptional professionals. You won't have to listen to me.
There was a question in the chat that I will share with Chelsea and the person who did the question, so we can let her go. Anybody else, if you need information, I'll be happy to share the contact information. And I think her study is amazing because of how deep she dug into the data, and it's helpful to all of us. And I thank her for being with us.
Excellent. All right. Well, thank you so much. Thank you all for your wonderful questions. Yeah. All right. Thanks, Alex.
Thank you so much.